fellowship in cardiology at Tulane University and also at University of California, Los Angeles. He is currently distinguished professor of medicine at Toronto University and also director of Pacific Electrophysiology Research Institute. And we'll be giving a talk on two topics. One is the catheter ablation and left atrial appendage occlusion for the AF, and then the next one will be update on Brugada syndrome. Dr. Lee, please.
Thank you very much, Dr. Shai. Ladies and gentlemen, good morning. First, I'd like to thank Mr. and Mrs. Chairman for inviting me here and organizer. Everything is superb. My task today is to discuss with you about catheter ablation. First session is atrial fibrillation and then Brugada syndrome, and I will give you an overview. The two areas that have been working for many years now. First, I'd like to highlight the development of the and progress of catheter ablation. First, we have to thank Dr. Cox, who introduced to us the modified Mays surgical procedure. And in 1995, the really good electrophysiologist John Schwartz introduced catheter-based modified Mays procedure. And at the time when I listened to his talk, I went to USC at the time I was there and did the modified Mays procedure with the catheter. Procedure was really long and complicated, but it relatively had a good success. And then in 1998, Michel Hasiguera from Bordeaux showed that the pulmonary vein is a very important area to trigger atrial fibrillation. And he subsequently developed the lasso catheter and technique to isolate the vein. And in Milan, Paponi do the circumferential wide area of the ablation. At the time, I changed from modified Mays procedure and do electrogram guided ablation. We published that in JACC in 2004, but we were doing it since 2000. And we abandoned modified Mays procedure altogether. Until 2006, because of the popularity of the lasso catheter and the isolated pulmonary veins become a very, very easy target for people to do. So PVI became a cornerstone of atrial fibrillation. The word cornerstone here, even though I was part of the committee of the HIS, and I could not outward the cornerstone. Anyway, in 2012, there was interest in the rotor mapping championed by Dr. Narayan with the phase mapping. And here we are up to date, everything is confused. The only thing is clearly, no question about that, is the pulmonary vein is a very important structure, not only from trigger atrial fibrillation, but also perpetuate. People ask me all the time, why didn't I do a PVI? And the reason, because if you really look into atrial fibrillation ablation technique and you want to see what is really good, you don't just want to have it for sinus rhythm alone. What you really want to do is you have to really, as far as the efficacy concerned, as listed here, highlight of success in maintaining sinus rhythm, and then highlight success not only the short term but also the long term. And the fewer number of the redo procedure, redo procedure will have it, but if you minimize it, then you're doing a really good thing, especially in the patient who have persistent atrial fibrillation. And the outcome is not only the sinus rhythm. The money is that if you can reduce stroke risk, improve morbidity and mortality, and reduce hospitalization and improve quality of life. And obviously, any procedure, you have to have a really good safety. And we felt that the way how I've been doing is really good. This slide just to show you, I'm sorry to show some of the elect EP slide, but I put the catheter in the right superior pulmonary vein, And then you can see here the trigger from pulmonary vein and initiate atrial fibrillation. And the area here is also perpetuated atrial fibrillation. Although all I did is just to isolate, not isolate, I'm sorry. That's a really bad word for me. Just ablating around this area until the atrial fibrillation stopped. And I tried to reduce it again, I could not reduce. You can see the whole procedure here, I did it in less than an hour. And I just did look like I was isolating the left superior pulmonary vein, but I didn't. I just did it to get rid of all those trigger PAC and eliminate the atrial fibrillation until I could not reduce again. The other vein were free. This patient now had been free of atrial fibrillation for over 7-8 years now. So this is, I have many cases like that just to show that pulmonary vein is very important structure and it contributes to atrial fibrillation genesis in many patients, but isolate all 4 veins, it's just that you just indiscriminately thinking that all atrial fibrillation the same. We published this paper in 2004, and I not just to show off, but one thing is interesting because a lot of centers could not reproduce our procedure, but the citation is still a lot. Even up to the last year, we have over 200 citations. So CAFE means something. And this is a patient that started them on. This is in the figure 1 of our paper. This is at 80 years old. And that back in patient was sent to me to do a modified med procedure. This patient had he was a retired general in the army and has significant diastolic heart failure, had chronic atrial fibrillation, failed all the drug, and eventually the patient underwent AV nodal ablation, and you can see here the pacemaker, even though he still has symptoms. So his cardiologist sent to me and said, well, we just do a modified med because the patient couldn't take it. A lot of people thought that I was crazy, that took the patient at 80 years old back then in 1999 to do the procedure. But when I put the catheter into the heart, this is really almost like a God gift to us. You can see here the recording in the right atrium. The electrogram is very nice and organized, it's very slow. The cycle length about 235. But along the septum on the right atrium and left atrium, which I will show you later, show multiple diffraction, fractionated electrogram, low voltage, and the cycle length is very short, 120, 50, and or sometimes 50. In average, it's about less than 100 milliseconds, almost twice shorter than the other side of the atrium. And so I went ahead and mapping this area and ablating. When I did the modified med at the time, I was doing this anyway, from pulmonary vein to the septum to the fossa ovalis, and then pulmonary vein here to the mitral annulus, and then I did the cable tricuspid each month, SVC to the fossa ovalis, and then all the post-row septal, and so on. But because I'm going to do this area anyway, and all this area where you see the fractionated signal, like that, and as I was ablating, and you can see from the letter, this map back then it was not very good in the current standard, but nevertheless it did the job. The cycle length progressively increased, and eventually when I keep ablating, AFib stopped. Now, before I did this case, I had performed about 50 modified med procedure. The procedure took about 6 hours, and I terminated AFib to sinus rhythm in only 2 patients. I had to do cardioversion in 48 patients or so. This patient, I did it, the whole thing less than an hour. From this one. So I said, wow, this is great. So since then we hypothesized that this fractionated signal is important. And we published it in 2004. And this is some of the sample of 4 patients, 2 had persistent and 2 with paroxysmal. For the interest of time, I'm not going to explain much, but you can see here, not all the patients the same, and in the area that I have to ablate it, not much. Allow the pulmonary vein antrum is still very important, and all these patients, we published in 2004, I didn't know what's going to happen to them. All these 4 patients, except one that committed suicide, about 8 years later, they're all still in sinus rhythm. The other thing is very important when we map the area it's not only just fractionation alone, but it's cycle length, short cycle length is very important. And when we see like this, we call it rapid filing, and especially usually coming around the antrum of the vein, corny sinus and crista terminalis in the right atrium. And we usually, because the electroanatomical mapping, we can tag and map it nicely. Now, I want to show you example that not everywhere, every patient have pulmonary vein foci. This patient is a physician of OB from Chicago and had exercise-induced atrial fibrillation like this. Very symptomatic, and he could not function very well. So I took him to the lab, and you can see here the recording here from the corny sinus. The 7 and 8 is in the proximal corny sinus, and the catheter is also around that area. And basically, when ablating around the corny sinus, I terminate AF and render it non-inducible. And all I did is just here. All I did is just here. And this patient had been in sinus rhythm. He's a physician, refer a lot of patients to me over 15 years now. Now, since then we published more paper in the high risk in the elderly, but now they fast forward to currently that we have been doing the past 2 years. We now doing a combined electroanatomical mapping and check for the AF trigger, initiator, and perpetuator. We want to get with them all. And the trigger is just like what I showed you before, that the atrial premature with the trigger atrial tachyarrhythmia. Not necessarily at the beginning to be atrial fibrillation, but it could become like an atrial tachycardia, SVT, and then that's what we call atrial AF initiator before degenerate to AF. And the perpetuator is where you can see focal activity, rotor, and then cafe. And I have to thank this Michelle Hazegara and Melis Corsini sent me the cardio insight, the ECGI, to do it in Bangkok, and then to do the atrial fibrillation ablation. And this is our workflow. The patient came in, not stop, continue to take anticoagulation, and we put the ECGI when we have a 252 body surface electrode, the record unipolar electrogram of the torso. The patient then underwent CT scan to get the anatomy of the heart, and then we can segment it to the map, and then can show the depolarization, repolarization, and the mapping of the phasic mapping of the rotor. And then with the vest intact, we took the patient to the lab. And here is how we put the lab in. Both the front and the back of the torso. This is a patient, example of a patient that came in with paroxysmal atrial fibrillation in silent rhythm. We gave patient isoproterenol, and then we induced PAC coming from the right superior pulmonary vein again, and induced atrial fibrillation. And this is the carto map, anatomical map of the left atrium, right atrium here in the pulmonary vein. And this is the area where the PAC coming from. Again, we know that now the trigger is coming from the right superior pulmonary vein. What is the map look like in the ECGI? This is body surface mapping simultaneously during the PAC. And you can see the earliest activation in the right superior pulmonary vein, and it orderly propagated to the left atrium and landed in the lateral wall of the right atrium. What does sinus look like? The sinus look like this in this patient. It's starting somewhere in the up on the top in the superior cava, and then go to the top of the left atrium, and evenly distributed between the right and left atrium, and the latter in along the inferior wall, compared to the PAC from the right superior pulmonary vein. Now, when we did it in independently. I didn't influence about the mapping of the ECGI, and you can see here the area of the perpetuator in this patient. It's not in the right superior pulmonary vein, just like the first patient I'm telling you. Because you see rapid filing in the antrum of the left superior pulmonary vein from this multiple electrode. And in this area, this is the AP view, this is the PA view. This is right superior pulmonary vein, this is the left superior. This is the area that perpetuates. That you can see here the rapid filing of the short cycling. So because of it, then now we can identify the trigger and perpetuator. And what the face look like, I'm going to show you the movie. This is the anthem of the left superior pulmonary vein, and you can see the rotor around this area. See that? Multiple rotor. When anything that's more than 1.5 or 2 rotor, then you know question that this is the whole thing is driving the atrial fibrillation. And when we ablate it this side, it changed to atrial flutter. This is the typical when you do substrate ablation. You do not really change from atrial fibrillation to sinus rhythm all the time. It changed to some type of atrial tachycardia. One can say that it may be the hidden initiator. And when you see this, you know right away. This is either calvo-tricuspid isthmus flutter or the area from the postural septum. And the ECGI also show the same thing. The earliest activation is in the postural septum, the coronary sinus node, and you can see the line of block. So basically, this is look like a counterclockwise atrial flutter, and we should ablate the isthmus and terminate the rhythm. Now, nice we terminate and everything, but that's what not our endpoint. Our endpoint is non-inducible, so we try to use the isopratolinol again to induce. We could not induce atrial fibrillation, so we used the next thing we did is to give adenosine. Adenosine now to induce PAC from the right superior pulmonary vein, induce atrial flutter and atrial fibrillation again. So what does it tell us at the time? That means that even though we burn right superior pulmonary vein, it's still not, we didn't achieve permanency. So because, and then it unmasked by the adenosine, so we burned it the same area again until we could render non-inducible at the end, and then we stopped the procedure. The whole thing take about 1 hour and less than 2 hours. Full load time is 5 minutes and 7 seconds, and RF time 9 minutes 33 seconds. Okay, and we are confident with our result because we also, in many patients, the majority of our patients have device implanted that we can monitor atrial fibrillation burden either with the pacemaker or the recorder reveal link. And then this is an example of our patient that had paroxysmal atrial fibrillation, and you can see after ablation, their AF burden became 0, and with the long-term follow-up that we have. I think I have 5-10 minutes before that. I just want to quickly just show you patient with persistent atrial fibrillation patient. This is patient who have persistent atrial fibrillation longer than 6 months, and we map the same way. And this just to show you, this is the carto map, electroanatomical map that show abnormal area in the right superior pulmonary vein along the loop and the septum. And this number here is showing focal activity and rotor along the same area of the right superior pulmonary vein. This is the RAO view, this is the AP view, and this is posterior wall. So you can see here again is around the vein and also in the carina of the pulmonary vein. And then when you record the electrical signal, you see dispersion, complex fractionated electrogram in this area of the antrum of close to the septum anteriorly to the right superior pulmonary vein. And then in this area, we also can see the multiple, And when we play the movie, you can see here that this one is almost like a butterfly figure 8 inches. in the right superior pulmonary vein, confirming this. So we know that now that this area is very clear, predominant to be a subject for the atrial fibrillation, and we ablated those areas and resulting to termination. We believe that the way how we've been doing with the subject ablation, we achieve termination of atrial fibrillation, not to atrial tachycardia, to sinus rhythm over 95% of the time. And yielding a very nice long-term success rate, as you can see here. This is the data from the pacemaker and ICD implanted in the patient that we can measure atrial fibrillation burden or atrial tachyarrhythmia burden in majority of the patients. So even after 4 years, we still achieve very low AF burden in the majority of the patients. But that's nice. But what we really pleased, albeit this is retrospective study, and just show in the population of elderly over 75 years old, we have like 216 patients we published in heart rhythm, and you can see here the patient with normal sinus rhythm after 2 years show improved survival, and the benefit it happened after 2 years. Recently, they have a heart failure study they published in the England Journal. If you see the result also showing that the benefit in the mortality improvement in the heart failure population, also the benefit started after 2 years. And even those group AF fibrillation did not achieve in majority of the patients, but the AF burden significantly reduced. What happened to the stroke reduction? Well, this is the data. We were able to stop warfarin in over 85% of the patients. On the top, the blue curve and Kaplan-Meier is the patient that we stopped warfarin and stay in sinus rhythm, and the yellow, the patient that we were not successful and we stay still in Coumadin. So we were very happy with that, and we believe that, and this is a patient, elderly patient, that they enjoy their life. This is 82, now he's 85. The Caltech professor. She's a very liberal activist, work for Obama. She's 94 years old. This is over 8 years now. Every year she bought a cookie for me for an anniversary of ablation. This patient is the most touching. He's almost 100 years old before he died 2 months after he came to see me because of the infection. But this patient have the CRT ejection fraction 30%, but he lived, I ablated the two times. The last time was about 12, 14 years before this. So, and none of these patients taking Coumadin. Well, the next thing that we have to talk, and then you heard the wonderful lecture by Dr. Koonlawee about the atrial occlusion, left atrial appendage occlusion. I'm not going to dwell too much. I just quickly to show you. I do not do this much because I feel that most of my patients, when they have a successful atrial fibrillation ablation, then I do not have to do anything. For as you have heard, the left atrial closure device, you have epicardial approach and endocardial approach. And in a way, there's only for interventional electrophysiology that you have the LARIA, tissue closure, and the endocardial and the Watchman. There are other devices also, but these are the most popular. And you heard about the atrial clip from Epikill from Dr. Koonlawee, but I just wanted to briefly show you these two, LARIA and the Watchman. I don't have a lot of time. I just want to show you that the LARIA, you have to go the epicardial and the endocardial approach. That actually better to show you the movie. The epicardial, you have to put the chip into the epicardial, and then you do a transeptal to the, then you go to the left atrial appendage. The catheter had a magnet, and then go to this side. and also had a balloon in the to occlude it into the ostium of the appendage. This catheter also had the magnets that they can find each other very nicely. And one is connected. This is very important that you have to have a very good coaxial. Then you can put the suture going surrounding the until to the neck and the of the appendage. And here, then inside here, you have a suture, and you blow the balloon, and then close it the appendage. And then you apply the suture, and then remove the magnets, and then the catheter retract it drawn. And you can see the suture out, and then this part it can be tricky because it's not easy where sometimes with the appendage is too big, and then you have to be very careful. And then you usually advance and cut the suture. And the good thing about this is you do not have the endocardial artifact in the heart. And this is just to show you the appendage before and the appendage after the radial portion. Initially, there's some post-procedure death in about, I think, almost less than 1%. But for people who had more experience, then I believe it much better. However, this is not and the result is pretty good. You still have some event about 1.3% compared to the national registry with offering. The watchman, you see the picture briefly also. Because in interest of time, I just want to show the watchman is a bit different. It's an endocardium, and you do a transeptal with the TE guided, and now there's some center using intracardiac echo, and this is a cartoon that to show that we go to the femoral vein, and then you do transeptal puncture, and then advance to the appendage. Usually, when we put the transeptal in, we will position in the left superior pulmonary vein first, and then later on withdraw, and then advance into the left atrial appendage. The transeptal, we prefer to do it posterior and inferior, so that it could go to the appendage much easier. This technique also sometimes it encounter the difficulty because the appendage has different type. The easiest type is with stop, but the broccoli is also okay. But the chicken wing that's coming up, this is more very difficult. Because you can see here that sometimes you cannot really anchor it very nicely. This windsock is the most easier one to occlude it. So you advance the pigtail so that you can eject the contrast also, and then you advance the sheet, the delivery sheet, which have the marker to tell you the area, because there are three sizes of the Watchman device that you have to choose to fit with the appendage. You like to put it just past the ostium to make sure that you have maintain a good occlusion. The Watchman went through the delivery sheet and access sheet, and then you just retract it, inflate the balloon, provided you find a good side, and you do a tucking to make sure that it deploys properly. And you at this time we also check the flow to make sure that no flow in and out the atrial appendage to ensure, and then you can withdraw the whole thing. For those sites that are doing a lot, this procedure took less than 20-30 minutes. I'm not that good because I don't do that much, but I just want to tell you. I just want to go right to the data. Watchman is probably the most studied, and it's the only occlusion device that had randomized trial. And I show you quickly. The safety is very good. The complication rate is about 3 to 5%, depending on center, and the 45-day stopping warfarin or anticoagulation is 87%. After 12 months, it's more than 93%. But the stroke rate is not 0. Okay, then you still have some stroke rate. And here, this is the efficacy for the long term from 3 randomized trial. So it's showing it. Watchman is a good device that can reduce the stroke related complication from atrial fibrillation, and you can decide which one that you like to use, the epicardium or endocardium. But Watchman is the most popular one. Well, I'm going to stop here before I go to Bugada. If you and I would be happy to entertain any question you may have.
Thank you, Dr. Yu. Any question from the floor?
That lariat device that uses the epicardial approach, look at the string, tie the left atrial appendage. I was really scared of it. It's going to tear the left atrial appendage. Because as a cardiac surgeon, you always, in the past, you always tie the left atrial appendage outside. Oftentimes, we have to. Do you have any experience with that?
So far we haven't had that try yet, but there have been a report of the significant tamponade, and there was one death. I don't know the tear that happened is because the way you described. I couldn't tell because it happened too early on. But so far, a lot of people who have done a lot have no problem with it. So, but I mean, I hear you.
Yes.
เดินหรือบอกก็ได้ใส่ไปอยู่เองไม่ได้
Thank you for the nice talk. One question: what is your pharmacological strategy after the ablation procedure? What do you give to your patients? Those amiodarone, beta blocker, what is mix?
Thank you for asking. We stop all antiemetic drug before the patient came in. If amiodarone, we stop at least 1 month, if possible. We do not stop anticoagulation. We do the patient on anticoagulation. That's the best thing to do. And when we finish, I try not to put the patient on anything. Not like most centers. We do not. And if I were to use drug, because obviously atrial tachyarrhythmia or even atrial fibrillation during the first 3 months after the procedure is not uncommon. If I have to use antiemetic drug, I would use amiodarone or sotalol because short-term amiodarone is no problem. But I try not to use it. Sometimes I just do the rate control drug like verapamil or calcium channel blockade or beta blockade. If I have to use antiemetic drug, I like to use amiodarone. The patient, the long-term result, I show you less than 7% of patients on antiemetic drug. None of those patients were on any antiemetic drug long-term.
So you've shown us rather old patients, which was rather surprising to me. So we all know that there are patient groups with not so good results, where the results of EVI is less than 50%, the one with giant atria, the one with long-standing persistent arrhythmia. So what are the patients you would not touch?
No, I wish I'd show you the patient that have the, I do not have any patient that I would not do, but I would tell the patient the following. if the patient have left atrium 6 centimeter within atrial fibrillation over 4 years, I would quote my first session success rate is 60%, 50 to 60%. And I would tell them that the redo, the chance to redo is at least 40%. And I would tell them also that once they go into the heart, if I saw that the heart is so chronic and scar everywhere, I probably would not ablate and I would not bring them back. We had a patient, I didn't have time to show you, that have 2 valve replacement aortic and mitral. The ejection fraction 30%, and we did only 1 session. That was a pure luck maybe, and the ejection fraction came back to normal. Left atrial shrunk. That patient had mitral valve, had mitral stenosis and AI. And you can see our first patient that we published, that was 80 years old. So, and you could see that patient that didn't do much. So it is true that patients who had high risk like heart failure, big left atrium, elderly patient, the chance to be success is not the same as the normal heart or the patient 55, but it doesn't mean you cannot do it. In fact, all these patients, I could tell you that because we've done over 400 elderly patients, that's the best thing you could do to the elderly. Because they don't have to take any anticoagulation, they feel free, and most of our patients are very active.
It's interesting that you mentioned that you did the ablation in somebody with AF for the last 4 years.
Yeah.
My experience is that the longer the duration of the AF, the less likely the patient is going to end up with a stroke. That the more recent AFs are the ones that are at risk of a stroke. So I have raised this at most cardiac meetings, saying that the people who are involved with electrophysiology should re-look at the guidelines about anticoagulation in atrial fibrillation. We as cardiac surgeons, when we are operating on mitral valve disease, we have seen plenty of clots in the left atrium sitting very happily in the left atrium, and the patient has never had a stroke. You get what I mean? So what I'm trying to get at is that...
I know what you mean, but I don't know why we'll agree.
Yeah, what I'm trying to get at is that a thrombosis in AF is not the same as thromboembolism in AF. Now, in the recent onset AF, the patient is having paroxysmal AF, and that is the patient at high risk of thromboembolism. A lot of my patients who have AF more than 1 year, I actually terminate their anticoagulants. And at the most, I will give them an antiplatelet. I'm not following the guidelines, but my patients have not suffered from it. So I would make a plea to the people who look after atrial fibrillation patients, re-look at the data and maybe change the guidelines.
Well, that's not a lot of that study that showed. If you look at the CHA2DS2-VASc score, if you have a 75 years old and who had hypertension, most of our patients in this study had hypertension, and you don't put him on warfarin or NOAC, the risk of stroke is about above 10 to 15%. There's a study done by Professor Yip from Birmingham that, in fact, there's only one randomized study that was done in elderly. Compare warfarin and aspirin or antiplatelet. It is very clear that the group that taking aspirin has a very high rate of stroke. So and then there are other long-term studies like SPAD3. So I don't know. I hear you and I respect your opinion, but that's not what most people observe.
You know what I'm trying to say? The CHA2DS2 score does not include type of AF.
No,
AF is not one disease.
I agree with you.
Right.
I agree with you that AF is not the one disease, but persistent AF and paroxysmal AF, the risk of stroke is no different.
No different?
No, I don't think so.
I don't believe it.
Well, that, as I said, I respect your opinion, and let me tell you that I don't have to tell you, you will be in a minority on that one.
Okay, thank you very much. I'll give